Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Salicylates have been recognized for their medicinal properties for centuries. The ancient Egyptians used myrtle and willow leaves for pain relief, while Hippocrates utilized willow bark and leaves to reduce fever. The active ingredient in willow, salicin, was extracted in 1829 and employed as a fever reducer. 7 years later, salicylic acid was isolated, and by the late 1800s it was used to treat various conditions such as gout, rheumatic fever, and elevated body temperature. In 1833, a less irritating form of salicylic acid was synthesized, which eventually led to the commercial introduction of acetylsalicylic acid as aspirin in 1899 by Bayer. This development marked the start of the modern era of aspirin therapy and also brought attention to salicylate toxicity. Between the 1950s and the 1970s, salicylates were responsible for the majority of fatal poisonings among children. However, the occurrence of unintentional salicylate poisoning decreased over time. This decline was due to several factors, including the recognized link between aspirin use and Reye's syndrome, the implementation of safer packaging methods, and the increased use of alternative medications such as nonsteroidal anti-inflammatory drugs, acetaminophen, and other options to aspirin. Despite these advances, salicylates remain widely available and continue to cause significant health issues, including morbidity and mortality, particularly when overdosed. By the end of this session, you will be able to define and describe the history, properties, and mechanisms of action of salicylates. You will also learn to identify various sources and formulations of salicylates, including aspirin and non-aspirin types. Additionally, you will understand the pathophysiology of salicylate toxicity, focusing on the progression from respiratory alkalosis to metabolic acidosis. The session will cover how salicylates disrupt oxidative phosphorylation and the Krebs cycle, leading to increased lactate production and metabolic acidosis. You will gain insight into the physiological and pharmacological effects of acidemia resulting from salicylate poisoning, particularly how it enhances tissue penetration and causes toxicity in the central nervous system. Furthermore, you will learn about the impact of salicylates on blood clotting, including the inhibition of vitamin K-dependent clotting factors and the effect of aspirin on platelet function. The discussion will include the toxicokinetics of salicylates, emphasizing the dose-dependent nature of absorption, distribution, and metabolism. The limitations of the salicylate toxicity assessment tool, known as the Dunn nomogram, will be explained, along with the importance of clinical correlation in diagnosis. You will be guided through the key steps involved in assessing and evaluating a patient suspected of salicylate toxicity, which includes taking a thorough history, conducting a physical examination, and performing essential laboratory investigations. The differences between acute and chronic salicylate poisoning will be compared and contrasted, highlighting variations in presentation, diagnosis, and severity. The management of salicylate poisoning will be discussed, emphasizing supportive care measures, reducing gastrointestinal absorption, enhancing elimination, and the use of extracorporeal removal techniques. You will learn about the rationale for using multiple-dose activated charcoal in specific scenarios and the crucial role of urinary alkalinization in increasing renal elimination of salicylates. The advantages of lactated ringers solution over normal saline for fluid resuscitation will be outlined. Finally, the indications, benefits, and procedures for extracorporeal elimination techniques, primarily hemodialysis, will be explained. Salicylate toxicity initially causes respiratory alkalosis by directly stimulating the respiratory center in the brainstem. This results in rapid and deep breathing, leading to increased elimination of carbon dioxide from the body. As a consequence, the blood becomes alkaline, a condition known as alkalemia, which is commonly observed in adults presenting early with acute salicylate poisoning. However, as toxicity advances, metabolic acidosis develops, counteracting the initial respiratory alkalosis. Several factors contribute to this shift, including the uncoupling of oxidative phosphorylation, inhibition of enzymes within the mitochondrial matrix, and increased production of lactate. Salicylates impair the process of ADP production by uncoupling oxidative phosphorylation. Normally, in mitochondria, electrons travel through the electron transport chain located on the inner mitochondrial membrane, releasing energy that drives the pumping of hydrogen ions from the mitochondrial matrix into the inner membrane space. This creates an electrochemical and pH gradient essential for synthesizing ADP, as hydrogen ions re-enter the mitochondrial matrix through ADP synthase, providing the energy needed for this process. The terminal step involves electrons combining with oxygen to form water. Salicylates interfere with this process by reducing the hydrogen gradient across the membrane. They do so by crossing the inner mitochondrial membrane and releasing hydrogen ions into the matrix where the pH is higher. The remaining salicylate molecules or other anions are then transported out of the mitochondria. Additionally, salicylates can form pores in the membrane that are permeable to various substances, including hydrogen ions. This collapse of the hydrogen gradient decreases ADP synthesis despite continued electron transport and oxygen consumption. As a result, energy is released as heat instead of being captured to produce ADP, which can lead to hyperthermia, a potentially life-threatening complication. Beyond uncoupling oxidative phosphorylation, salicylates also inhibit enzymes in the mitochondria such as alpha-ketoglutarate dehydrogenase, a key enzyme in the Krebs cycle. This inhibition diminishes the production of NADH and FADH2, primary electron donors for the electron transport chain, further reducing ADP production and contributing to metabolic dysfunction. The uncoupling process forces cells to rely more heavily on anaerobic metabolism for energy production, which increases the generation of pyruvate from glycolysis. Under normal conditions, pyruvate enters the mitochondria and fuels the Krebs cycle. However, in salicylate poisoning, the uncoupling and enzyme inhibition limit the mitochondria's ability to utilize pyruvate effectively. Excess pyruvate is then converted into lactate, which regenerates NAD+, a crucial coenzyme for glycolysis. The accumulation of lactate, along with keto acids and other organic acids, contributes significantly to the increased anion gap characteristic of metabolic acidosis. Although lactate levels may remain normal or only slightly elevated in many cases of salicylate poisoning, they can occasionally be markedly increased. It is important to note that glucose conversion to lactate does not directly produce hydrogen ions. Instead, the primary source of hydrogen ions that cause acidosis is the accelerated hydrolysis of ADP due to increased reliance on glycolysis. In summary, salicylates indirectly elevate lactate production by impairing oxidative phosphorylation and inhibiting key enzymes in the Krebs cycle. This forces cells to depend more on anaerobic glycolysis, leading to lactate buildup and metabolic acidosis. However, lactate itself is not the main source of hydrogen ions responsible for the acidity. The onset of metabolic acidosis initially normalizes the blood pH, bringing it closer to the physiological range. However, as the acidosis worsens, it overcomes the effects of respiratory alkalosis, leading to acidemia, which is characterized by a low blood pH. Several factors can hasten the transition from respiratory alkalosis to metabolic acidosis. Delay in seeking treatment allows more time for significant metabolic acidosis to develop, especially if the patient remains untreated for an extended period. The co-ingestion of central nervous system depressants, such as benzodiazepines and opiates, can blunt hyperventilation caused by salicylate toxicity. This masking effect prevents the typical respiratory alkalosis from manifesting clearly, thereby enabling metabolic acidosis to appear more rapidly. Young children are also more susceptible due to their limited ventilatory reserve. This makes them less capable of establishing a strong initial respiratory alkalosis and more prone to early development of metabolic acidosis. This progression from respiratory alkalosis to metabolic acidosis illustrates the dynamic nature of salicylate toxicity. Healthcare providers should be aware of this evolving acid-base imbalance to manage patients effectively and prevent complications, such as the penetration of salicylates into the central nervous system, which is facilitated by acidemia. The complex interaction between respiratory and metabolic disturbances underscores the importance of frequent monitoring of blood pH, electrolyte levels, and salicylate concentrations in patients suspected of salicylate poisoning. The anion gap is a calculated value that represents the difference between the concentrations of positively charged ions, known as cations, and negatively charged ions, known as anions, in the blood. In a simplified explanation, the main cations are sodium and potassium, while the major anions include chloride and bicarbonate. The anion gap is determined using a specific formula: the sodium concentration plus the potassium concentration minus the chloride and bicarbonate concentrations. A typical reference range for the anion gap falls between 5 and 21 millimoles per liter. An elevated anion gap often indicates the presence of unmeasured anions in the blood. This can occur in various medical conditions. For instance, toxic alcohol poisoning, such as for methanol or ethylene glycol, results in the production of organic acids like formate and glycolate, which contribute to an increased anion gap. Lactic acidosis is another condition associated with an elevated anion gap. It occurs when there is excessive production of lactic acid, often due to poor tissue oxygenation. Additionally, ketoacidosis, which involves the buildup of ketone bodies such as acetoacetate and beta-hydroxybutyrate, can cause an elevated anion gap. This is commonly seen in individuals with diabetic ketoacidosis or alcoholic ketoacidosis. The mnemonic CAT mud piles helps in recalling the common causes of anion gap acidosis. The letter C stands for cyanide and carbon monoxide. A represents arsenic, while T signifies toluene. The letter M can refer to either methanol or metformin. U denotes uremia, and D covers diabetic ketoacidosis and alcoholic ketoacidosis. P includes propylene glycol, paraldehyde, and paracetamol, also known as acetaminophen. I corresponds to iron and isoniazid. L stands for lactate, and E represents ethylene glycol. These associations provide a memorable way to identify the causes of anion gap acidosis. Acidemia, or low blood pH, resulting from salicylate poisoning, is a serious condition. It develops as metabolic acidosis progresses, eventually surpassing the initial respiratory alkalosis. This condition has numerous harmful physiological effects, leading to a range of severe symptoms. As blood pH decreases, more salicylic acid shifts to a non-ionized form that can easily cross cell membranes, increasing tissue penetration. A slight drop in pH from 7.4 to 7.2 nearly doubles the amount of unionized salicylate, allowing greater access to tissues such as the brain and heart. This enhances toxicity even as serum salicylate levels decline. Acidemia also worsens toxicity within the central nervous system. The high energy demands of the brain make it particularly vulnerable to the toxic effects of salicylates. Autopsy findings often reveal cerebral edema in individuals who have died from salicylate toxicity. Symptoms of severe neurotoxicity include agitation, confusion, hallucinations, lethargy, seizures, and coma. In terms of cardiovascular effects, Acidemia and impaired production of ADP in the heart muscle contribute to an increased heart rate, known as sinus tachycardia. Severe acidemia can further lead to low blood pressure and heart failure. It can also trigger ventricular arrhythmias such as sudden ventricular fibrillation and conduction abnormalities like heart block. Regarding respiratory effects, initial hyperventilation results from direct stimulation of the respiratory center, but as acidosis worsens, respiratory depression may occur. This is due to heightened central nervous system toxicity and fatigue from prolonged hyperventilation. Additionally, salicylate-induced acute respiratory distress syndrome, characterized by increased permeability of pulmonary capillaries and fluid buildup in the lungs, can contribute to respiratory acidosis. Acidemia also exacerbates metabolic disturbances caused by salicylate toxicity. It worsens hypokalemia through increased renal potassium loss and can lead to hypoglycemia by depleting glycogen stores and impairing the process of glucose production in the liver. While hyperthermia is not as common as other symptoms of salicylate toxicity, it represents a serious complication, often observed in severe cases and among individuals who succumb to poisoning. The presence of rapid heart rate, excessive sweating, and central nervous system dysfunction, particularly when accompanied by acidemia, serves as an ominous sign indicating a high risk of deterioration and death if aggressive treatment is not promptly initiated. Hyperthermia occurs when the body attempts to compensate for inefficient energy production. In response, the metabolic rate increases, generating more heat. This compensatory mechanism involves higher oxygen consumption, depletion of liver glycogen stores, increased breakdown of tissues, and substrate catabolism. In severe cases, individuals may develop extreme muscle rigidity, a condition known as perotonia. This heightened neuromuscular activity further amplifies heat production, which can lead to rhabdomyolysis, a breakdown of muscle tissue. Additionally, salicylates can directly influence the hypothalamus, the brain region responsible for temperature regulation, disrupting normal thermoregulatory processes and potentially contributing to hyperthermia. The acid dissociation constant of aspirin, known as acetylsalicylic acid, is 3.5, while its active metabolite, salicylic acid, has a dissociation constant of 2.97. The dissociation constant of a weak acid, such as aspirin, indicates the pH level at which half of the molecules are in the ionized form as a salt and half are in the non-ionized, uncharged form. At a lower pH, which corresponds to an acidic environment, a greater proportion of salicylate exists in the non-ionized, lipid-soluble form. This form can easily cross cell membranes, including the blood-brain barrier. During conditions of acidosis, the decrease in blood pH shifts the equilibrium toward the non-ionized form of salicylic acid. As a result, its ability to penetrate tissues, including the central nervous system, increases. This causes a wider distribution of salicylates within the body. More salicylate leaves the bloodstream and enters tissues, which leads to an increased tissue burden of the drug. Such a shift may worsen toxicity, even if the levels of salicylates in the blood serum appear to be decreasing. Acidemia, or increased acidity in the blood, heightens the risk of central nervous system toxicity because the brain is particularly sensitive to the effects of salicylates. The primary strategy for managing salicylate toxicity involves maintaining a higher blood pH through the administration of sodium bicarbonate. This process, known as alkalinization, helps to trap salicylate in the bloodstream by converting it into its ionized form. The ionized form is less capable of penetrating tissues and is more readily eliminated by the kidneys. Salicylates, including aspirin, can influence blood clotting in two main ways. Firstly, they can inhibit the synthesis of clotting factors that depend on vitamin K. Similar to how the blood thinner warfarin works, salicylates interfere with the liver's production of these vitamin K-dependent clotting factors. They do this by preventing the reduction of vitamin K quinone to its active hydroquinone form, which is necessary for producing factors 2, 7, 9, and 10. Consequently, there can be a deficiency of prothrombin, and other vitamin K-dependent factors, potentially leading to prolonged clotting times. Despite these effects, severe bleeding complications are uncommon in salicylate poisoning, with gastrointestinal bleeding being a rare exception. Elevated clotting times typically appear 8 to 24 hours after an overdose and usually respond promptly to vitamin K1 treatment. Salicylate toxicokinetics exhibit significant variability and pose challenges in the management of poisoned patients. Several factors influence how the drug behaves in the body at toxic concentrations. The formulation of salicylates plays a crucial role. For instance, effervescent and enteric-coated preparations can markedly affect the rate of absorption. Enteric-coated tablets, in particular, may lead to delayed absorption and initially misleading levels that appear non-toxic. Chronic ingestion of enteric-coated aspirin can also result in the formation of gastric bezoars, which further prolongs absorption. Additionally, the rate at which the stomach empties impacts how quickly salicylate is absorbed. Changes in gastric pH, such as those caused by medications like proton pump inhibitors or H2 antagonists, can alter the absorption dynamics of salicylates. Distribution of salicylate involves its binding to proteins, primarily albumin at therapeutic levels, with about 90% bound. When toxic concentrations are reached, protein binding decreases to less than 75% due to saturation of binding sites, resulting in a higher proportion of unbound, pharmacologically active salicylate that can more easily diffuse into tissues. The volume of distribution of salicylate rises as its concentration increases from approximately 0.2 liters per kilogram at lower levels to between 0.3 and 0.5 liters per kilogram at higher levels. This volume expansion becomes more pronounced during overdose. Acidic conditions in the body also promote the movement of salicylate from the bloodstream into tissues, especially the central nervous system. This shift increases the apparent volume of distribution and can exacerbate toxicity, even if serum salicylate levels decrease. Salicylic acid, which has a pKa of 2.97, predominantly exists in an ionized form at normal physiological pH. However, during acidosis, more of the salicylate converts to the non-ionized, uncharged form. This form can easily cross lipid membranes, including cell membranes, enabling the salicylate to enter cells and cause toxic effects across various organs. Metabolism and elimination of salicylate vary depending on the dose. Elimination is dose-dependent, with half-lives ranging from 2 to 4 hours at therapeutic doses, but extending up to 20 hours at toxic concentrations. The prolonged elimination at toxic levels results from the saturation of metabolic pathways and an increased volume of distribution. Salicylate is primarily metabolized in the liver through processes such as glucuronidation and conjugation with glycine. These pathways become saturated at therapeutic concentrations, leading to zero-order elimination kinetics, meaning a fixed amount of the drug is eliminated per unit time regardless of the drug's concentration. As hepatic metabolism becomes saturated, renal elimination assumes an increasingly important role in clearing the drug. However, factors such as dehydration and aciduria can significantly impair renal clearance. In cases of chronic toxicity, the volume of distribution is larger. Patients tend to experience more severe clinical effects at lower serum concentrations compared to acute toxicity. This is because, over time, salicylate distributes more extensively into tissue compartments, especially the central nervous system. The dynamic nature of how salicylate is processed in the body makes interpreting serum levels challenging. The Dunn nomogram is not recommended for assessing salicylate toxicity because it has significant limitations. Historically, this nomogram was used to estimate the degree of toxicity based on a serum salicylate level drawn 6 or more hours after ingestion. However, it can both overestimate and, more importantly, greatly underestimate the severity of toxicity. A patient with a salicylate level in the mild range on the nomogram may still become severely ill hours later, especially if acidemia or dehydration is not addressed or if salicylate levels continue to rise. The nomogram does not account for essential factors such as the patient's acid-base status, hydration status, ongoing absorption of salicylate, or individual variability. The nomogram primarily relies on a single serum salicylate concentration, which can be misleading, particularly in cases of chronic toxicity or delayed absorption. Declining serum levels do not necessarily indicate improvement, as they could reflect increased tissue distribution and worsening toxicity. Relying on this tool can lead to a delayed diagnosis and treatment of potentially life-threatening salicylate poisoning. Because of the body's complex and changing processes in response to toxicity, especially regarding pH and tissue distribution, it is crucial to consider the entire clinical picture rather than focusing solely on a serum level. Evaluating a patient with suspected salicylate toxicity requires a comprehensive approach that considers the dynamic nature of salicylate toxicokinetics and the potential for rapid clinical deterioration. While much of this discussion discusses aspirin, it is important to recognize that many other salicylates exist and all can contribute to this toxidrome. One such compound is bismuth subsalicylate, an over-the-counter medication commonly used to treat diarrhea under the brand name Pepto-Bismol. Although generally safe when taken as recommended, repeated or excessive use can lead to salicylate toxicity due to its salicylate content of 8.7 milligrams per milliliter. Methyl salicylate, or oil of wintergreen, is found in topical liniments, solutions used in hot vapors, and some flavoring agents. It is the most concentrated form of salicylate, with a 98% solution containing 1,400 milligrams per milliliter. Even small ingestions or excessive topical application, especially when combined with heat exposure, can cause severe toxicity and potentially be fatal. Topical salicylates, used as keratolytics containing salicylic acid or as rubefacents with methyl salicylate concentrations up to 30%, are generally safe, but can be dangerous if applied excessively over large areas or to damage skin, increasing absorption and risk of poisoning. Salicylic acid itself is a key metabolite of all salicylates, responsible for their pharmacological and toxic effects. Other salicylate-containing products available over the counter or by prescription include choline salicylate, magnesium salicylate, salsylate, sodium salicylate, sodium thiosalicylate, and triethanolamine salicylate. These agents are converted to salicylic acid during or shortly after absorption, making it crucial to be aware of multiple potential sources of exposure and the risks associated with both intentional and unintentional overdose or misuse. When assessing a patient, rapid clinical evaluation begins with a thorough examination of vital signs, mental status, and respiratory effort. Subtle signs such as increased respiratory rate or hyperpnea should not be overlooked, as these early indicators of respiratory alkalosis often precede metabolic acidosis and can prompt further investigation. Tachycardia, sweating, and altered mental status, particularly in the setting of acidemia, are ominous signs of severe toxicity. A detailed history should be obtained regarding the type of salicylate product ingested, the estimated amount, and the timing of ingestion. It is also important to inquire about any underlying medical conditions, especially those affecting kidney or liver function, as these can exacerbate toxicity. Physical examination should focus on the respiratory system, assessing for signs of distress such as rapid, labored breathing, and on neurological status, looking for agitation, lethargy, confusion, seizures, or coma, indicators of significant central nervous system involvement. Laboratory investigations include measuring serum salicylate levels, although initial concentrations may not always correlate with severity, and decreasing levels could reflect increased tissue distribution rather than clearance. Blood gas analysis is essential to determine acid-base status. Salicylate poisoning often presents with a mixed acid-base disturbance, initially with respiratory alkalosis, progressing to metabolic acidosis as the condition worsens. The presence of respiratory acidosis at presentation suggests severe systemic toxicity. Electrolyte testing is important to evaluate for hypokalemia, which is common in salicylate poisoning, as well as hypochloremia resulting from vomiting and respiratory alkalosis. It must be noted that salicylates can interfere with laboratory assays, potentially leading to falsely low chloride and a misleadingly normal or negative anion gap. Thus, clinical suspicion should guide interpretation. Serum glucose should be monitored because salicylates can affect glucose metabolism and cause hypoglycemia. Administration of dextrose may be necessary, especially in patients with altered mental status, regardless of their initial glucose level. Checking for serum or urine ketones is also recommended, as these may be elevated in poisoning. Elevated lactate levels are markers of tissue hypoxia and increased anaerobic metabolism caused by salicylate interference with cellular respiration, with concentrations above 2.25 millimoles per liter indicating severe outcomes. Renal and hepatic function tests are essential to identify pre-existing impairments that could affect the elimination of salicylates, with elevated creatinine indicating potential kidney injury and increased liver enzymes suggesting hepatic dysfunction. Coagulation studies, such as prothrombin time and international normalized ratio, should be obtained to evaluate for bleeding risks, given salicylate's effects on platelet function. Additional assessments include an electrocardiogram to detect cardiac arrhythmias or conduction disturbances and a chest X-ray if respiratory distress or hypoxemia is present to evaluate for pulmonary edema. The symptoms of salicylate poisoning can mimic other conditions involving metabolic acidosis, respiratory alkalosis, gastrointestinal distress, or central nervous system dysfunction. Differential diagnoses include sepsis, diabetic ketoacidosis, alcoholic ketoacidosis, hepatic failure rise syndrome, and poisoning by other substances such as theophylline or caffeine. Salicylate intoxication can occur suddenly following a significant single dose or develop gradually from repeated exposure to smaller amounts. Due to their widespread availability, salicylates remain a major cause of illness and death, underscoring the importance for clinicians to be proficient in recognizing and managing salicylate poisoning. In cases of acute poisoning, the process often affects young adults with a history of psychiatric illness or prior overdoses, frequently related to suicide attempts. These individuals may openly admit to ingesting salicylates or be found with partially used containers of the medication. Symptoms usually appear within 1 to 2 hours after ingestion and include ringing in the ears, dizziness, nausea, vomiting, and rapid breathing. Elevated salicylate levels in the blood, typically above 40 to 50 milligrams per deciliter, are commonly observed at this stage. Tinnitus, characterized by a ringing or hissing sensation in the ears, is a common feature of salicylate toxicity, especially in acute cases. Despite this, its clinical significance is limited because it varies widely among patients and does not reliably correlate with serum salicylate levels or the severity of poisoning. It does, however, indicate central nervous system toxicity as it results from salicylate's direct effect on auditory pathways in the brain. This symptom can manifest even in the absence of other neurological signs. Historically, tinnitus was considered an indicator of potential toxicity, but research shows it is an unreliable predictor of illness severity. Some individuals experience tinnitus at therapeutic drug levels, while others with toxic levels may not. Age-related hearing loss can also influence tinnitus perception, complicating its interpretation, particularly in chronic poisoning cases. Studies further reveal that there is a weak association between tinnitus presence and blood salicylate concentrations, highlighting the limitations of relying solely on this symptom to determine toxicity. Although tinnitus should not be used alone to assess severity, its presence warrants a thorough evaluation, including a detailed history, physical examination, and measurement of serum salicylate levels. The absence of tinnitus does not necessarily indicate safety, especially if other symptoms or risk factors are present. Chronic salicylate poisoning is more common among individuals taking acetylsalicylic acid therapeutically who inadvertently overdose. Due to pre-existing high tissue levels of the drug and saturated elimination pathways, additional intake can cause a significant accumulation of free salicylate, extending the drug's normal half-life from 2 to 4 hours to as long as 20 hours. Usually, lower blood levels of salicylate are needed to cause symptoms in chronic poisoning than in acute cases because of the considerable amount stored in tissues, including the brain and spinal cord. While increases in blood levels often correspond to symptoms in acute toxicity, such a correlation is often absent in chronic poisoning. Patients with chronic poisoning frequently exhibit neurological disturbances such as agitation, confusion, hallucinations, slurred speech seizures, and even coma. An expression used to describe this condition is the salicylate JAG, which refers to restlessness and mental disturbances resembling intoxication from alcohol, due to delays in diagnosis and treatment, often because the condition is mistaken for other illnesses like infections, diabetic ketoacidosis, or dementia. The morbidity and mortality rates are higher with chronic salicylate poisoning. Relying solely on blood, salicylate levels can underestimate the severity of chronic poisoning and delay necessary treatment. Instead, medical decisions should be guided by the overall clinical picture, including symptoms, acid-base balance, and the patient's general condition, with blood levels serving only as an additional tool. In acute poisoning, rising blood levels usually correlate with severity. However, in chronic cases, this relationship is less reliable, and patients may experience severe symptoms even with lower serum concentrations. Over time, the drug distributes into tissues, especially the central nervous system, resulting in higher tissue concentrations than reflected in blood tests. Treatment of salicylate poisoning centers on supportive care and increasing the elimination of the drug, as there is no specific antidote available. Initial management involves stabilizing the patient and providing support. It is important to assess the respiratory status carefully and ensure adequate oxygenation and ventilation. Intubation should only be considered if there is clear evidence of hypoventilation and respiratory failure. The decision to intubate a patient with salicylate toxicity must be made cautiously because a brief period of apnea during the procedure can worsen the acid-base imbalance and lead to more salicylate entering the central nervous system, which may cause rapid clinical deterioration. If intubation becomes necessary, an emergency consultation with a nephrologist for possible hemodialysis is strongly advised. Circulatory stabilization is also critical. Maintaining the patient's blood pressure and addressing any fluid or electrolyte imbalances, especially dehydration, are essential steps in managing salicylate poisoning. Reducing gastrointestinal absorption of the toxin involves several strategies. Activated charcoal can be administered to absorb salicylate and reduce its absorption. This treatment is most effective if given within 2 hours of ingestion, but can still provide benefits even if the ingestion was delayed, particularly in cases involving enteric-coated tablets, large quantities, or bezoar formation. Repeated doses of activated charcoal every 4 hours may be required until the charcoal appears in the stool and clinical improvement is observed. Some sources suggest that multiple-dose activated charcoal, given every 4 hours over a period of 36 hours, might enhance salicylate elimination, but its effectiveness compared to a single dose remains uncertain. Whole bowel irrigation with polyethylene glycol electrolyte solutions may be considered to further reduce absorption, especially when enteric-coated preparations are involved. However, evidence supporting routine use is limited, and some studies have shown that this method, combined with repeated doses of activated charcoal, does not necessarily increase salicylate clearance. Contraindications for gastrointestinal decontamination procedures include vomiting, altered mental status, an unprotected airway, and gastrointestinal bleeding. Enhancing elimination through urinary alkalinization is a fundamental aspect of treating salicylate poisoning and should be implemented in all patients showing symptoms. The primary goal is to increase urinary excretion by alkalinizing the urine to a pH of 7.5 to 8, which traps ionized salicylate within the tubular lumen and promotes renal clearance. Elevating the urine pH from 6.1 to 8.1 can boost salicylate elimination by up to 18 times. In addition to increasing urinary excretion, alkalinization reduces tissue distribution. By raising the plasma pH, the equilibrium shifts towards the ionized form of salicylate, limiting its penetration into tissues, especially the central nervous system. To achieve this, an initial dose of sodium bicarbonate is administered at 1 millimole per kilogram of body weight, followed by a continuous infusion of sodium bicarbonate at a concentration of 150 milliequivalents per liter in dextrose solution administered at a rate of 150 to 250 milliliters per hour. The objective is to maintain a serum pH of approximately 7.45 to 7.55 and a urine pH of around 8. Hypokalemia is a common complication in salicylate poisoning and can hinder effective urinary alkalinization. Therefore, potassium supplementation is often necessary to keep urine alkalinized. Serum potassium levels should be closely monitored and doses adjusted as needed. Aggressive fluid resuscitation is also crucial to correct dehydration, improve renal blood flow, and aid in the elimination of salicylates. It is important to monitor fluid status carefully and modify infusion rates based on the patient's clinical response and urine output, aiming for a urine flow of 2 to 3 milliliters per kilogram per hour. Extracorporeal removal methods are essential in certain cases of salicylate poisoning. Hemodialysis is the most effective technique for eliminating salicylate from the body and is recommended for patients experiencing severe toxicity. Indicators for initiating hemodialysis include a serum salicylate level exceeding 90 milligrams per deciliter, regardless of symptoms, as well as severe clinical manifestations such as altered mental status, seizures, coma, pulmonary edema, or cardiovascular instability. It is also indicated in cases of impaired renal function or if the patient does not respond to aggressive supportive care. Additionally, the presence of other significant co-ingestants requiring dialysis may warrant this intervention. When hemodialysis is not available or contraindicated, hemoperfusion and continuous renal replacement therapies can be considered, although hemoperfusion might be less effective in correcting fluid and electrolyte imbalances. In neonates with severe toxicity, exchange transfusion can serve as an alternative treatment if hemodialysis is unavailable. Monitoring is a vital component of management. Clinicians should closely observe the patient's clinical status, vital signs, acid-base balance, electrolytes, and salicylate levels, repeating salicylate measurements every 2 to 4 hours until the levels decrease to a low concentration and the patient's blood pH is within a normal or elevated range. Maintaining normal body temperature and aggressively treating fever are important. Glucose should be administered as needed to address hypoglycemia. Electrolyte abnormalities, especially low potassium levels, should be corrected promptly. Seizures should be managed with benzodiazepines, and vitamin K may be administered in cases of coagulopathy. Multiple-dose activated charcoal is recommended to enhance the elimination of salicylates, especially in cases involving suspected pharmacobezoars or extended-release preparations. It effectively prevents the absorption of unabsorbed salicylates, surpassing the efficacy of a single dose of activated charcoal. This is particularly useful when a pharmacobezoar, which is a solid mass of undigested medication, or an extended-release formulation is suspected, as these conditions can cause prolonged and unpredictable absorption of salicylates. In situations where serum salicylate concentrations remain elevated or continue to rise despite initial administration of activated charcoal, administering repeat doses can be beneficial. These additional doses can help lower plasma salicylate levels and are especially helpful in treating bezoars. If salicylate levels persistently increase or fail to decrease despite appropriate management, a bezoar should be suspected, and the use of multiple doses of activated charcoal is warranted. Although the role of multiple-dose activated charcoal in enhancing salicylate elimination through gastrointestinal dialysis remains somewhat controversial, several studies and expert recommendations support its use in specific scenarios. One study demonstrated that administering activated charcoal every 4 hours over a 36-hour period increased the total amount of salicylate excreted from the body. However, it remains unclear whether the primary benefit of this treatment was prevention of further absorption or active elimination. Another volunteer study showed a 9% to 18% increase in total salicylate excretion when 25 grams of activated charcoal was given at 4, 6, 8, and 10 hours after a dose of 2,800 milligrams of aspirin. Many toxicologists also recommend administering additional oral charcoal if serum salicylate concentrations increase after initial treatment. Overall, administering 2 to 4 properly timed doses of activated charcoal is generally advised. Nevertheless, the decision to use multiple doses should be carefully considered against the potential risks of vomiting and aspiration, particularly in patients with altered mental status or unprotected airways. It is crucial to consult a toxicologist for guidance on the appropriate use of multiple-dose activated charcoal in cases of salicylate poisoning, as individual patient factors and clinical presentation are essential in determining the best course of treatment. Lactated Ringer's solution is generally preferred over normal saline for fluid resuscitation in cases of salicylate poisoning. Normal saline can worsen acidemia because it can contribute to a normal anion gap metabolic acidosis, which lowers blood pH. This is problematic because acidemia increases the proportion of uncharged salicylate in the blood, promoting its movement into tissues, including the central nervous system, and potentially intensifying toxicity. In contrast, lactated Ringer's solution contains lactate, which is metabolized by the liver into bicarbonate. This bicarbonate helps buffer excess hydrogen ions associated with metabolic acidosis, thereby reducing acidemia caused by salicylate poisoning and helping to maintain a more balanced acid-base status. Additionally, lactated Ringer's solution may be more effective than normal saline in restoring extracellular fluid volume. Salicylate poisoning often leads to dehydration due to factors such as vomiting, rapid breathing, and sweating. Because of its balanced electrolyte composition, lactated Ringer's solution can more effectively rehydrate the patient and correct electrolyte imbalances. Overall, lactated Ringer's solution is preferred for initial fluid resuscitation in salicylate poisoning because it is less likely to worsen acid-base disturbances and may better restore fluid and electrolyte balance. Renal elimination is essential for removing salicylates from the body, especially during overdose conditions when the hepatic metabolic pathways become overwhelmed. Free salicylic acid undergoes passive reabsorption and active secretion in the proximal tubules of the kidneys. The extent of reabsorption is influenced by the pH of the urine. In acidic urine, a greater proportion of salicylic acid remains in its non-ionized form, which is more lipid-soluble and is reabsorbed more readily across tubular cell membranes. Salicylate conjugates, such as salicyluric acid and glucuronides, are produced in the liver and are also filtered by the glomerulus and secreted by the proximal tubules. These conjugates are not significantly reabsorbed because of their limited lipid solubility. Consequently, their elimination primarily depends on the glomerular filtration rate and the secretion activity of the proximal tubules, and it is unaffected by the urine's pH. The pH of the urine plays a critical role in the renal clearance of salicylic acid. Since salicylic acid is a weak acid with a pKa of approximately 2.97, its form depends heavily on the pH environment. In alkaline urine, salicylic acid exists mainly in its ionized form, which is polar and less capable of penetrating lipid membranes, thereby reducing reabsorption. This ionized form tends to be trapped in alkaline urine, decreasing its reabsorption across kidney tubules. In contrast, in acidic urine, more salicylic acid remains in its non-ionized lipid-soluble form, which is quickly reabsorbed across tubular membranes, resulting in decreased urinary excretion. Increasing the urine pH from 5 to 8 can significantly enhance renal salicylate clearance from about 1.3 milliliters per minute to 100 milliliters per minute. This increase in clearance dramatically shortens the drug's half-life from around 310 hours to just 4 hours. Two primary mechanisms explain this pH-dependent elimination. The first is ion trapping, which involves filtering both ionized and non-ionized salicylate at the glomerulus. However, only the non-ionized form is readily reabsorbed. Alkalinizing the urine traps more salicylate in its ionized form, thus decreasing reabsorption and boosting excretion. The second mechanism is diffusion. In alkaline urine, the rapid ionization of non-ionized salicylate creates a steeper concentration gradient, promoting the diffusion of non-ionized salicylate from the peritubular fluid into the urine. Therefore, alkalinizing the urine is a fundamental approach to treating salicylate poisoning. This is typically achieved through the administration of sodium bicarbonate. Keeping the urine pH at or above 7.5 significantly enhances salicylate elimination and reduces its toxic effects. Extracorporeal elimination techniques, primarily hemodialysis, play a vital role in managing severe salicylate poisoning. These methods work by rapidly removing salicylate from the bloodstream, correcting acid-base disturbances, and addressing electrolyte imbalances. Hemodialysis is highly effective at removing salicylate because the drug has a low molecular weight, is highly water-soluble, and has a low volume of distribution. Additionally, at toxic levels, a greater percentage of free salicylate is present due to saturation of protein-binding sites. Hemodialysis is recommended when the salicylate concentration in the blood is 100 mg per deciliter or higher, or 90 mg per deciliter or higher if the patient has impaired kidney function. It is also indicated when the patient shows altered mental status, has new hypoxemia requiring supplemental oxygen, or when standard supportive measures and bicarbonate therapy fail. In such cases, if salicylate levels are 90 mg per deciliter or more, or if they are 80 mg per deciliter or higher with impaired kidney function and systemic blood pH is below 7.20, hemodialysis is advised. The benefits of hemodialysis include rapidly reducing serum salicylate concentrations, correcting acidosis and electrolyte disturbances, and managing volume disturbances caused by poisoning. The procedure usually involves high-flux membranes with blood flow rates around 400 milliliters per minute, achieving extraction ratios between 35% and 70%. Most patients require 4 to 6 hours of dialysis to lower salicylate levels to below 20 milligrams per deciliter. In cases of prolonged absorption, longer or repeated sessions may be necessary. Other extracorporeal techniques include charcoal hemoperfusion, which effectively removes salicylate but does not immediately correct electrolyte and acid-base imbalances and carries risks such as thrombocytopenia and hypocalcemia. Continuous renal replacement therapy offers an alternative, especially in unstable patients or when hemodialysis is unavailable. This method, which can involve continuous venovenous hemofiltration or hemodiafiltration, produces a rapid reduction in serum salicylate levels. Sustained low-efficiency dialysis is a lesser-known option that has shown comparable clearance rates to other continuous therapies, although clinical experience is limited. Peritoneal dialysis is generally less effective than hemodialysis and should only be considered if other options are unavailable. In neonates, when hemodialysis is inaccessible, exchange transfusion may be used. It is crucial to involve nephrology specialists early to anticipate complications and initiate extracorporeal therapy promptly. Although these methods are highly effective, decisions regarding their use should carefully consider individual patient factors, potential risks, and the severity of poisoning. Salicylates, which are primarily known for their use in aspirin, have a long history of medicinal application dating back to ancient civilizations. However, their widespread availability and utilization have also contributed to significant instances of morbidity and mortality resulting from both acute and chronic overdoses. Understanding the toxin. Salicylates include a variety of compounds such as aspirin, bismuth subsalicylate, methyl salicylate, and numerous topical and prescription formulations. Recognizing the potential for toxicity from any of these sources is crucial. The primary mechanism underlying salicylate toxicity involves interference with oxidative phosphorylation and the Krebs cycle. This disruption causes a shift towards anaerobic metabolism, leading to the accumulation of lactate and organic acids. As a result, metabolic acidosis occurs, which can be life-threatening. Recognizing the poisoning. Salicylate poisoning typically presents as a mixed acid-base disturbance. In the initial stages, respiratory alkalosis is observed due to direct stimulation of the respiratory center in the brainstem. This early alkalosis can mask the underlying metabolic acidosis, complicating early diagnosis. The severity of salicylate toxicity is closely linked to acidemia or low blood pH. Acidemia enhances the penetration of salicylates into tissues, especially the central nervous system, thereby worsening neurotoxicity. The clinical manifestations vary depending on the severity and duration of the poisoning. Acute poisoning often presents with symptoms such as ringing in the ears, vertigo, nausea, vomiting, and rapid breathing within a few hours after ingestion. Chronic poisoning, which can result from therapeutic mishaps, may show more subtle and nonspecific symptoms, including neurological abnormalities, making diagnosis difficult. Managing the toxicity, treatment focuses on supportive care and promoting the removal of the drug from the body. There is no specific antidote for salicylate poisoning. Early stabilization of vital functions and supportive measures are essential, ensuring the airway remains open, breathing is adequate, and circulation is stable. Correcting fluid and electrolyte imbalances, particularly dehydration, is a priority. In the early stages, reducing absorption of the toxin from the gastrointestinal tract is vital. Administering activated charcoal within 2 hours of ingestion is recommended, as it can bind to the salicylates and reduce absorption. In cases where absorption is delayed or prolonged, multiple doses of activated charcoal may be beneficial. Urinary alkalinization, achieved by administering sodium bicarbonate, plays a central role in treatment. This process increases the pH of urine, facilitating the trapping of ionized salicylates in the renal tubules and promoting their excretion. In severe cases, extracorporeal removal techniques, such as hemodialysis, can be life-saving. Hemodialysis rapidly clears salicylates from the bloodstream, corrects acid-base disturbances, and manages electrolyte imbalances. Key takeaways. Effective management involves treating the patient based on their clinical presentation rather than solely relying on serum salicylate levels. Symptoms, acid-base status, and overall condition should guide treatment decisions. Early recognition, aggressive supportive care, and timely interventions are essential to improve outcomes in salicylate toxicity. Consulting a toxicologist is recommended in all suspected cases, especially those with severe or complicated presentations. By understanding the mechanisms of toxicity, clinical signs, and appropriate treatment strategies, healthcare professionals can better manage cases of salicylate poisoning and reduce the risk of serious complications or death.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.